I was asked to present about management of TB and HIV co-infection, and I will cover some epidemiological aspects, then healthcare infrastructure, and also clinical aspects of management of this co-infection. So if you look at epidemiology and start with some boring numbers, actually, while preparing this presentation and reading through WHO and the ECDC report, I noticed that numbers are not so boring any longer, and they start to see optimistic. As you can see here, we observe in Europe, we observe decrease, maybe not in the rate we would like to see, but still there is a decrease in TB rates and also in TB mortality. Where we need to pay more attention is that TB rates among HIV-positive persons are still stable, and as well as HIV and TB mortality. So overall, it's a report published in 2019, but data are from 2017, and overall 21% decrease was observed in identification rates of new TB cases and relapses during 2013 and 17. A percentage of newly notified TB patients tested by using WHO-recommended rapid diagnostic test increased from 22% to 50% in 2017, which is very good. That means that we identify more resistance cases and we have a better resistance profile of Mycobacteria tuberculosis. 91% were screened for HIV, and HIV prevalence among TB patients in Europe is around 13%, and as I mentioned, it continues to be more or less stable. So what about MDR-TB and XDR-TB? This is our biggest problem and challenge in Europe. And overall, around 30% of tested TB cases were multi-drug resistant, and proportion of MDR-TB in previously tested TB cases reached up to 50%. There is also a big increase in XDR-TB cases, as you can see here. In a majority of cases, I think it reflects improved diagnosis, but it doesn't minimize our challenges. And treatment success rate also remains to be a challenge. So for drug-sensitive TB, we have 77% of successfully treated patients, which is not yet a goal. And the proportion of successfully treated patients for TB among drug-resistant cases is significantly lower, and it's about 50–60%. So we have the global plan to end TB, and our targets are reach 90% of all people to diagnose at least 90% people with TB, and then to reach at least 90% treatment success rate. So let's look at some examples, and here are data extracted from ECDC report 2019, and I took just random countries as representatives. Here there is no conflict of interest at all, and for example, Poland and Romania represent Central Eastern Europe. Estonia, Latvia, and Lithuania are representing post-Soviet countries, but currently members of European Union. Then Belarus, Russia, and Ukraine, it's Eastern European countries with highest HIV prevalence and also highest prevalence of MDR-TB. And Kazakhstan is a representative of a STAN country. So in general, notification rate is rather high. So we diagnose around 90%, and in some countries, as for example Russia, we even identify more than estimated number of TB cases. And TB notification rate varies from 13% in Estonia to as high as nearly 80 cases per 100,000 in Russia. So if we look further, a rate of laboratory confirmed cases in general is between somewhere 75 and 85%, but in 2017 it was rather low, 50% in Russia and 64% in Ukraine. Drug susceptibility testing also proportion of tests performed is rather high. See, it is 100% among all laboratory confirmed cases in Lithuania and Belarus. It is nearly 100% in Estonia and Latvia, but some countries still face challenge in drug susceptibility testing. Among those tested for first-line TB drugs, rifampicin and isoniazid, MDR-TB was detected as low as 1% in Poland and as high as nearly 50% in Russia and Belarus. And then the next challenge is drug susceptibility testing for second-line drugs to detect XDR-TB, and also several countries do it at a rather high level. That means that 100% of MDR-TB cases were tested also for second-line drug resistance in countries like Latvia, Lithuania, Belarus, and Ukraine. But see here, for example, this test was not performed in Kazakhstan. And then prevalence among those who were tested for XDR-TB is as high as nearly 50% in Belarus, for example, and 40% in Latvia. And this is very good because if we test 100%, then we find all cases. But if we test, for example, only 40%, and among those we find 40% of MDR-TB cases, then we can only guess what numbers look like in the rest of the patients who were not tested for drug resistance. So what about HIV? If we look at 1990 program for HIV in Eastern Europe and Central Asia countries, columns marked here with a circle, we can see that we still need about 20% of patients, of HIV patients to be found in Eastern Europe. But look at this huge gap between those who were found positive, who were tested for HIV, and those who started antiretroviral treatment. This gap is the biggest in Eastern Europe compared to all other regions. This also reflects on data published by ECDC. HIV prevalence among TB cases varies from approximately 2% in Romania, 4% in Lithuania, to 20–22% in Russia and Ukraine. And antiretroviral therapy remains to be a challenge here. These are data from a cohort of 105 MDR-TB and HIV co-infected patients from Eastern Europe, and it reflects dynamics of antiretroviral therapy from the date of TB diagnosis, the first bar, until 21 months of follow-up. And just look here, the median CD4 cell count for HIV-TB patients at the time of TB diagnosis was 91. So patients were deeply immune suppressed at TB diagnosis, and still only around 13% of them were on antiretroviral therapy at the time of TB diagnosis. Proportion of those who started antiretroviral therapy increased within the months, but we can see here that some patients also apparently dropped from follow-up, and it was far from being sufficient. Only around 60% of patients were on antiretroviral therapy nearly 2 years after TB diagnosis. Now we will look a little bit on healthcare infrastructure for people living with HIV and TB in Europe in general and also in Eastern Europe. So first we look on policy levels. So this is the results from survey on collaborative TB-HIV activities. It was performed under initiative of WHO, and it reflects existing policies in countries. So it's not a practice, but rather guidelines and policy. The survey was performed between 2015-17, and we asked national TB and Asian national HIV coordinators in 55 European countries. We received a response rate of 85%. 47 countries send us their surveys back. So policies on testing and screening. See, HIV, 85 countries say that according to their policy and guidelines, all patients need to be tested for HIV. All TB patients need to be tested for HIV. 72% of countries do TB screening in people living with HIV, and 64% of countries do screening for latent TB in people living with HIV. At that moment, when we conducted survey, it was 2016-17, 91% of countries answered that all their HIV-TB patients should start antiretroviral therapy, and I hope that this percentage now increased to 100%. Policy regarding cotrimoxazole prophylaxis varied. Like, for example, 40% of countries recommend cotrimoxazole to all co-infected patients, and then 34% don't recommend it, and then 15% to some selected group of patients. I think we didn't do regional difference here, but I think the policy here varies between Eastern and Western European countries. So now we look which specialist provides screening for TB and HIV infection respectively. So in TB patients, screening for HIV is performed by TB specialists in 89% of countries, and 9% refers, TB specialists refers patients somewhere else for HIV screening, so they don't do it on site. TB screening in HIV patients performed by HIV or infectious disease specialists in 72% of countries, and 26% of countries send patients somewhere else for TB screening. What about treatment? Who treats TB HIV co-infected patients in hospital? So lungs here represent TB specialists and red ribbon HIV, and in 26 countries treatment for TB and HIV is performed separately in separate departments or separate units. 19 countries do it simultaneously in infectious disease department by HIV specialists, and in 2 countries responded that all treatment is performed by TB specialists. In 9 countries, the full TB treatment is given in hospital, and 38 countries say that they start treatment in hospital and then finish it at home. But when patients go home for outpatient treatment, in majority of countries it's still performed by different specialists. It could be monitored at the same facility, but by different specialists, and it could also be monitored at different facilities. Another survey looked at healthcare delivery for HIV-positive people on hospital level. So it's basically what do we do in practice and how our policies are implemented in practice. In 2018, we conducted a survey among 26 HIV and TB clinics, received response rate of 88%, 14 clinics in Eastern Europe and 9 clinics in Western Europe. And then we compared these results with the similar survey from 2013. So what we look here, the data are similar to policies that integrated HIV and TB services are to a much less extent in Eastern Europe, light blue bars, compared to Western Europe, dark blue bars. Also, HIV and TB patients are less likely to be treated by the same doctors in Eastern Europe, and TB and HIV follow-up is in different locations. Another aspects of healthcare shows that opiate substitution therapy is available to a much less extent in Eastern Europe and compared to Western European countries. So when we compared our results from 2018 to 2013, surprisingly, we didn't see any major improvements. And even worse, for example, the green-red bars represent 2013 and lighter red bars represent 2018. And you can see that here, for example, fewer clinics actually answered that they have integrated HIV and TB care services, which was rather surprising. On a positive note, we notice that availability of TB drugs is improving in Eastern Europe. It concerns rifampicin, but also to a larger extent second-line drugs such as fluoroquinolones, levofloxacin, and moxifloxacin, and also bedaquiline availability is improving in the region. We talk a lot about patient-centered care, and this is the first pillar of anti-TB strategy. Patients are at the heart of service delivery. So what does it mean? It means that patient-centered care is focused on and organized around the health needs and the expectations of people and communities rather than on patients or diseases. It should be focused on outpatient care rather than prolonged hospitalizations and decentralizations of model of care over centralized care. So we need to come to patient rather than the patient comes to us. There is some studies confirming this policy. So for example, it's a systematic review showed that programs provided psychological and material support have lower follow-ups rate and also better outcomes of HIV and TB patients. Another study also showed improved outcomes of MDR and XDR TB programs, MDR and XDR TB patients in decentralized and patient-oriented programs. So this was a bit of statistics and healthcare infrastructure, and now we move on to clinical aspects of co-infection. TB diagnosis is essential, and it needs to be laboratory confirmed to as many cases as possible. Number one recommendation at the moment is gene expert. It overrules all days microscopy, sputum microscopy. It has very good sensitivity and specificity rates close to 100%, and it should be used in all settings. The conventional TB diagnostic could be rather time-consuming and also resources-consuming. And if we first start with microscopy and then culture on solid and liquid media, and then conventional phenotypic drug susceptibility, it can take up to 2-3 months, which can be critical for many patients, especially with drug-resistant tuberculosis and HIV co-infection. And we should promote rapid genotypic tests such as line prop assays for second-line drugs, especially those who were detected with rifampicin resistance or multi-drug resistance. How do we treat HIV patients with tuberculosis? Our goal is to, of course, cure a patient, treat a patient from tuberculosis, but we also need to think about society and minimize spread of tuberculosis infection in the society. So when we mainly should treat our co-infected patients, first of all, we need to think when to start antiretroviral therapy. We need to consider significant pharmacokinetic drug-drug interactions between rifampicin and antiretrovirals. And we need to think about toxicity. We should remember about possibility to develop immune reconstitution syndrome. And we should remember that this is a multidisciplinary approach, integrated HIV and TB care, and these patients also need, in a large extent, for social and psychological support. So if patients are if it's HIV-positive patients known with HIV diagnosis and already on antiretroviral treatment, we should just continue this antiretroviral treatment. But we need to think about drug-drug interactions and also side effects, and adjustment of antiretroviral therapy might be needed. But what about those patients who are not yet on antiretroviral therapy? Back in 2010 and 11, results from these 3 large randomized trials were published, all studies concluded that the earlier we start antiretroviral therapy, the better is for the patients. It is now reflected in all guidelines, including EACS guidelines. We are currently updating it, and a new version will be published by EACS conference in November. So the guideline says that in co-infected patients with CD4 cell count below 50, we need to start ART as soon as TB treatment is tolerated and whenever possible within 2 weeks. So as soon as possible. If CD4 cell count is above 50, we can defer antiretroviral therapy. But still it is as early as possible. And particularly severely ill patients with meningitis due to high mortality rates, antiretroviral therapy should be started as soon as possible under close monitoring for adverse effects. In guidelines, you can find what antiretroviral drugs are to be used together with anti-TB treatment. It's, in general, it's TDF-FTC or TDF-3TC with efavirenz, but there is a tendency for usage of integrase inhibitors instead. We should remember about immune reconstitution syndrome, especially in patients with low CD4 cell count. And at the beginning of 2009, a large randomized trial was published in New England Journal of Medicine. The study was conducted in South Africa and involved co-infected patients with low CD4 cell count. Results of the study suggest that a prophylactic use of prednisolone in persons with CD4 cell count below 100 cells might have a good and positive effect on survival. So, and prednisolone doses is around 40 milligrams once daily for 2 weeks, and then followed by 20 milligrams for 14 days. If patients develop iris, then the treatment is corticosteroids. There is no much evidence for non-steroidal anti-inflammatory agents, yeah, and especially in TB meningitis, we need to use corticosteroids. Treatment failure or for treatment of tuberculosis. There is numerous reasons for this. Or we say 10 reasons for treatment failure, and from 1 to 7 is non-adherence. So adherence is crucial, especially patients with multi-drug resistant tuberculosis. They need to receive treatment for at least 2 years to ensure a good, successful outcome. So a lot of work should be done on improvement of adherence and compliance with these patients. But we should also consider, especially in cachectic malnourished HIV patients, a possibility of malabsorption or increased metabolism, intolerability of TB drugs, and might consider intravenous use of TB drugs to start with. If we want to succeed in treatment of multi-drug resistant TB, first of all, we need to proper diagnose and have a sufficient resistance profile of mycobacteria. And then secure the best possible anti-TB treatment regimen, and I will come back to it just in a few slides. And again, we need to secure adherence. Recently, 2 new anti-TB drugs have been approved, bedaquiline and delamanid. I know that bedaquiline is already highly used and available in a majority of Eastern European settings. Delamanid availability is a little bit behind, but hopefully it is improving as well. So in the beginning of this year, 2019, WHO published new guidelines for treatment of MDR-TB. We should choose a regimen of at least 4 to 5 drugs where Mycobacterium is susceptible. Group A is fluoroquinolones, bedaquiline, and linezolid. And if Mycobacteria is susceptible, we need to use all 3 drugs from this group. Group B is clofazimine and cycloserine, and again we need to use both drugs from this group, and then we add up according to susceptibility patterns from group C to complete at least 4 or 5 drugs regimen. If we look at costs of TB treatment, so if we can treat pan-sensitive TB for about 300–500 euros for the course, the treatment of XDR TB increases to 100–115,000 euros. And with the number of actual cases of XDR TB in Eastern Europe, so this becomes really a challenge. We should remember about toxicities, as a lot of antiretroviral drugs and anti-TB drugs have common toxicities. Hopefully some old, outdated toxic antiretrovirals are not used any longer, such as D4T and DDI. So to conclude, we observe high rates of MDR-TB in general and also among HIV-positive population in Eastern Europe, where high rates of primary MDR-TB, remember around 30% of cases, it reflects actually a poor infection control within the communities and societies. And MDR-TB among previously treated cases, remember it was about 50–70%, it reflects inadequate management, inadequate healthcare infrastructure, and poor patients' adherence. So this is the major pillars for improvement of treatment outcomes. We have also high prevalence of HIV infection, and availability of antiretroviral therapy still needs to be improved. Integrated and patient-centered care for TB and HIV is a key to successful treatment outcome. Remember it and try to adjust, adopt whenever and however it is possible. Then we need to ensure proper TB diagnosis, especially with such high prevalence of MDR and XDR TB cases. In order to combine a proper regimen, we need to have efficient DSTs, and we need to have a resistance profile. When we have an HIV patient with an unclear diagnosis, we need to always mind TB as a differential diagnosis. And we also know that HIV patients are at a much higher risk of developing active TB from latent infection, and therefore they should be closely monitored and likely receive prophylactic treatment. All patients with TB should start antiretroviral therapy if not yet on. It should not be 85%, it should not be 90%, it should be 100%, and especially for those with low CD4 cell count. But remember about drug-drug interactions. Remember to take care of immune reconstitution syndrome if it's developed. Adequate anti-TB treatment should be prescribed. It should be designed according to resistant patterns, and we need to ensure provision of second-line drugs. Also, treatment for MDR-TB is less effective, more toxic, and more costly. That's why from the very beginning, when we have first case of drug-susceptible TB in a patient, we need to ensure adherence in order to prevent development of MDR-TB in the future. We need more research. We need more research to understand biological mechanisms of interaction between MDR or TB in general and HIV. We need more research to monitor drug side effects and drug-drug interactions, especially with new drugs. We need more new anti-TB drugs in pipeline, and we need randomized trials to investigate optimal anti-TB treatment regimens and optimal duration of therapy. Many studies are already ongoing on this subject, and we are expecting soon results from them. Thank you very much for your attention.